So I want to first acknowledge the NIH grant support and my disclosures. We do have NIH-funded collaboration with both GE Global Research and Corning Corporation. So I'm going to spend a bit more time on the background side because breast CT is sort of unique, and people are not. We have a diverse set of audience here, so I'll spend a bit more time on what the breast CT is, and also about the radiation dosimetry and breast imaging in general and specific to cone beam breast CT. Our motivation for the study is we are now investigating a short scan breast CT system. So the question came up, where do we start? What's the start angle? What's your end angle for acquisition? So what's your trajectory that we need to do? And then the next question we had was looking at the breast shape varies between patients. So how does that shape affect the dosimetry? How does the distribution of fibroglandular tissue within the breast affect dosimetry? So that's the secondary motivation. And then we'll have a little discussion about a simplified analytical model that looks at the path length variation with projection angle. And most of it would be based on, the results are all from Monte Carlo simulations. So what is breast CT? Breast CT in current implementations are use prone breast patient geometry. That is, the patient lies on the table face down, and there's an aperture in the table, and the breast is pendant. And your gantry spins this way in the horizontal plane. So we acquired, right now, all the cone beam CT scanners do 360 degrees acquisition, full scan. And currently, there's one system in the United States that's FDA approved for non-contrast diagnostic use. I highlighted the diagnostic because there's often a bit of confusion about mixing mammography screening with diagnostic imaging, and I want to clarify that. If you have a woman who's asymptomatic, there's no reason to suspect any breast cancer, they come in for a mammogram, that's a screening exam. On the other hand, once they have had any symptoms, or they had a screen, and either the screen is just, the quality is not good, or they find a suspicious lesion, or the radiologist couldn't make a decision, they call them back, then it's a diagnostic exam. And most of the dosimetry, the dose limits that we talk about, and what's the dose from mammography, it's usually screening. The diagnostic dose could be way higher. So I wanted to highlight that because so we are talking about non-contrast diagnostic use. And the main reader study that supported the FDA approval process was used 235 cases. So all these patients had either a biopsy verification, either to show it's a cancer or a benign finding, or in the case there is nothing in the breast, there's no normal breast, you have to follow for 1 year to make sure there was nothing, have a second round of screening exam. And if that's also negative, then that's your truth for establishing a normal case or a negative case. So out of the 183 cases of benign and 79 cancers, 93 of them had calcifications, because it's a bit of a challenging issue here when you talk about breast imaging. You're trying to detect a low contrast soft tissue lesion in a soft tissue background on one hand. On the other hand, you're talking about very fine calcifications in the order of about 300 microns or less in that background. So you have two challenging in terms of imaging tasks, if you would. So about 50% of them had calcifications, and it was interpreted by 18 radiologists. So each radiologist read the breast CT images, and then the mammogram image, just separate sessions. And so the reader study, the analysis showed that the sensitivity improved, but the specificity and the area of the ROC curve were not different. So in all of breast X-ray imaging, the metric that we use to report dose is mean glandular dose. It's not CTDI. And as Dr. McNagray has said on this podium a few years ago, that's not the dose to the patient. So what is the mean glandular dose? It is the spatially average dose to the fibroglandular tissue. So within the breast compartment, that's outside, you have the skin. Within the breast, we can separate into two areas, the adipose or the fatty tissue, and everything else is bundled together as fibroglandular tissue. The reason is we know that the cancers don't originate in the fatty tissue. So the whole idea of dosimetry is finding what is the risk of radiation-induced cancer. So we are focusing on the fibroglandular tissue. So the dose metric is the mean glandular tissue. So how do we measure this? We don't use any phantoms. So at the isocenter or axis of rotation, you measure the air karma, which is basically a free in-air measurement. And once you do that, you know that what's the over full acquisition, what's the ionization air or air karma for that scan. Then you do Monte Carlo derived conversion factors. In order to do that Monte Carlo modeling, we need to have some shape assumptions of what the breast would look like. So here we are talking about an uncompressed breast pendant through the table. So we model that as approximately as a semi-ellipsoid. That's what our current dosimetry is for breast CT. So, so the semi-ellipsoid, your minor axis is basically the radius of the breast of the chest wall, and the major axis is the chest wall to nipple length. And within the compartment, we assume there's a homogeneous distribution of adipose and fibroglandular tissue. And then we say, oh, it's 50% fibroglandular, 50% adipose in a homogeneous mixture, or 15% fibroglandular to 50%. So you can run these simulations for different compositions. So so once you derive those conversion factors, then from your measurement, then you convert it from your air karma measurement, and from your conversion factor that is determined from Monte Carlo, you can compute the dose to a given breast, as long as you know the dimensions of the breast and what's the composition of the breast in terms of fibroglandular tissue. So using those dosimetry standards, this is the dose distribution that we've seen in cone beam breast CT. So the blue lines actually point out what's the dose from a diagnostic mammography workup. So you get anywhere from, the mean is about 12.5 milligray, and you have a very wide band. And the reason is, when you do diagnostic workup, they don't just limit it to 2 views or 1 view. Sometimes it's 1 view is enough. Sometimes they may have to do 10, 11 views till the radiologist is convinced that there is nothing in the breast. So it could vary between patients. So we have very large variance there. The actual median number of views is 4. The mean is 4.53, in case you're interested. And this is only for the breast where there is a suspicion of a finding. And so when breast CT started off, the dose was pretty high. It was about 13.5 milligray was the mean, but the variance was much smaller. The standard deviation was much smaller. The reason was it did not have AEC. So the technique factors were picked by the technologist choosing what technique factors to use. Then subsequently AEC was implemented, and it dropped down literally by 50%. And now with a few more for the tuning of the spectra, it's down to a little below 6 milligray. Our fundamental motivation for this is to take breast CT from a diagnostic use to eventually translate it to screening, and as a primary screening modality. That is potentially as a replacement for mammography and tomosynthesis. That is our long-term goal. In order to do that, we need to first meet some regulatory requirements first, and then we need to be somewhere within the dose range of what is being practiced today. So if you look at the regulatory requirement in the US FDA, you have a 3 milligray limit for a CC equivalent standard breast. In the cone beam in screening, we take 2 views: a craniocaudal view, where the breast is compressed this way, and you take from the detector is the bottom, and then the other one is a mediolateral oblique view, which is at an angle. So we want to replace these 2 views with 1 scan of an uncompressed breast. So the assumption is here that the 6 milligray limit is reasonable. But preferable is if we can stay within what is practiced today in the clinic. And in the clinic, we have 3 standards as far as screening goes. We have places where they do only digital mammography, and in which case for the 2 views, and if you look at the CC view dose, it's 1.62 milligray, and that's from the Akron Demas trial results. You get a 3.24 milligray for the screening exam. For the tomosynthesis, this is from Johannes's work, and you get 2.6 milligray for tomo. And then some places we also do the combo, both the tomo and the mammo together. And in that case, it's about 5 milligray. So we want to stay within that. So one way to do that is to do short scan acquisition. And again, as I mentioned before, we want to find out where to start and where to end. Now, if you can think about it, the homogeneous semi-ellipsoidal model, the cross-section is circular, and it's uniform composition. So at every angle, the dose is the same. So that's not an appropriate model for us to think about where to start and where to end, because you won't get, so we have to actually look at the clinical data for patients to see what's the real tissue distribution in patients. And so the second is to look at how does the shape change between patients vary at dose distribution. So we use non-contrast breast CT exams from 75 breasts, and they were all acquired with a prototype system. And it's a 49 kVp spectrum, 300 projections, and scan time is 10 seconds. It's a 300 micron size focal spot. And we reconstructed 273 micron voxels. And to cut the noise, we use a deep learning based assisted reconstruction, which is an FDK followed by a multi-scale residual dense network for denoising. And then we segment each slice into skin, adipose, and fibroglandular tissue. So this shows the left is the reconstructed image, the left A, the B is basically the segmented tissue distribution. The outside white line is the skin, and the white areas within the breast is your fibroglandular tissue, and the dark areas are your adipose tissue. Now, based on the fraction of fibroglandular tissue, we can replace it with the equivalent homogeneous background. So that's C, that's basically we retain the breast shape, but a homogeneous distribution. And then we can go back to what we are doing today for dosimetry, which is taking the cross-sectional area and equating to a circle with an equivalent area. So you basically do a semi-ellipsoidal breast with matched breast dimensions. Simulations were done using Monte Carlo with a gate, and the coefficient of variation in our simulations from 5 runs was less than 0.7%. So we did 5 sets of simulations here. For each of the 3 models, we acquire the full 2pi acquisition. And as I mentioned before, in model 3, we don't need to do it at every angle because it's the same dose at every angle. So we looked at only models 1 and 2 at each projection angle, and we discretized it over 10 angles. So our sampling in the projection, sampling in our angular sampling is 36 degrees for this dose estimate. So in order to understand how this is expected to vary, we looked at a very simplified model, and I mean it's really simplified. We know that the DG and CT, or the dose to the breast, is proportional to what is the energy deposited in the fibroglandular tissue. In order for energy to be deposited in the tissue, it first needs to be attenuated within the tissue. So for mono energy, we can compute what the attenuation is, and as a first order approximation, it is basically your linear attenuation coefficient times your path length for the ray. And so during the beam scan acquisition, your mu is fixed. It is not going to change because your beam quality is fixed. So it's independent of projection angle. So if you look at the path length variation as a function of projection angle, that could explain how your DG and CT is expected to vary over projection angles. Again, a very simplified geometry here, where we assume that breast is centered with the axis of rotation. Trying to get with the cursor in here. Oops. Oh, anyway, the AOR in the center is the axis of rotation, and your breast is aligned with the axis of rotation. We model the fibroglandular tissue as a circle, the gray circle, which is at a distance r, capital R, and the radius of that circle is a small r, and L is the distance from the source to the axis of rotation. And when you look at the orbit of that fibroglandular tissue, it's a circle, and then we can take one ray, and here we are looking at a ray at angle theta, and calculate what's the path length for that ray. And we're just going to model how it changes, just to give you an idea about what we expect in terms of DG and CT, how it's supposed to change with angle. So if you look at these simulations, then P0 is basically when your fibroglandular tissue is right at the center of axis of rotation. Of course, as you spin around, there is no change. So that's the horizontal line. And P0, P3 is when it's further away by distance r, but the polar angle is 0 here. And we see it follows a sinusoidal pattern. And here, the projection angle alpha equals 0 is when the X-ray source is at the head position. So when the fibroglandular tissue is close to the source, you have a higher path length, and consequently, we expect a higher dose. And because there's more chance of attenuation, and it's farther from the from the source, you'll expect a lower dose. So this gives an idea that, okay, if we know what's the fibroglandular tissue distribution, we can then estimate, well, which is the directionality to go for in terms of the short scan acquisition. So so for models 1 and 2, what we did was we first computed the center of mass of the breast and the center of mass of the fibroglandular tissue, and we aligned the center of mass of the breast with the axis of rotation, and then we plotted the spatial distribution of the center of mass of the fibroglandular tissue. And what we made sure is that the breast laterality is accounted for. So in all our drawings, the right breast is flipped to show the left breast. And when radiologists interpret, they usually say, oh, it's in the upper outer quadrant, it's in the upper inner quadrant. Upper outer quadrant is the one that goes towards the shoulders, towards the axilla. So we wanted to see the distribution because there is already some literature on the tissue distribution. So we plotted the center of mass. So this is for model 1. This is basically a heterogeneous tissue distribution and real shape. So each of the 75 points show where the center of mass of the fibroglandular tissue is. We find it's skewed toward the upper half of the breast. There's more fibroglandular tissue above the breast, above the nipple than below. And it's more towards the upper outer quadrant. And this is for model 1. On the right, you see for model 2, that model 2 is basically the shape with a homogeneous distribution. Now, you wouldn't normally expect to see any deviation because it's a homogeneous distribution. But what happens is that the skin thickness around the breast is not uniform. And that's why you get some small variations. And the X here marks the centroid in both these images. So we find about 80% of the breast are all in the upper quadrant, or on the upper quadrants. So that suggests that you want to avoid having the source close to it. You want to go have the source farther down. So, and here we look at where the centroid is. It's at 80.5 degrees in terms of the polar angle, which is close to 0 degrees in terms of our X-ray projection source angle. So, so this basically means that we have to have the X-ray source trajectory inferior to the breast. And here we find that it's very close to the axis of rotation in model 2, and it's actually within the voxel size of our images. And so there isn't much difference in terms of the shape of the breast itself. So in terms of our results, we find that between the 3 models, the model 2 and 3 is basically a semi-ellipsoid was the real breast shape with the homogeneous distribution. There's no significant difference. But if you take the real distribution, there is a difference. And it's about 6% lower dose compared to what we report. So that's fine. If at all anything, we are over-reporting the dose. That's fine. And if you look at how from Monte Carlo simulations, these are the dots are basically the data for each one of the projection angles, the distribution, and X is the mean. And the sign fit shows that it follows a sinusoidal pattern. And we find that the minimum occurs at 180 degrees. So that means if you're doing a short scan trajectory, you want to center the angular range to be below the breast, basically do an inferior trajectory to acquire your data. And if you're doing a full scan acquisition, if you want to implement tube current modulation, you may want to increase the dose when the X-ray source is below the breast and decrease the dose when the X-ray source is above the breast. So these are the 4 main conclusions in terms of, and if compared to what we do in terms of dosimetry today, if you do a short scan for the minimum angular range, which for this system geometry was 205 degrees, you can cut the dose by 52% if you maintain the same technique factors. And we have done some work on what that means in terms of image quality that was published 2 years ago. So, and we are also building an upright system. And for that system, with the system geometry, we can, compared to what's reported there, cut down the dose by about 50%. And then further improvement is possible with that additional advanced reconstruction algorithms. So in conclusion, homogeneous distribution, breast shape does not change dose. And compared to current dosimetry, if you use the actual patient tissue distribution, it's 6% lower. And for short scan, we want to use a inferior trajectory centered around the feet. And for full scan acquisition, you can tube current modulation with higher MA when the source is below the breast and lower MA when it's above the breast. Thank you.
Quick questions?
Hi, nice talk.
Thank you.
In the beginning, you mentioned that the CDDI is not a valid surrogate for the breast dose, but I think it should be somewhat closely related. Like there should be a great correlation between the mean glandular dose and the CDDI value of a, let us say, 16 centimeter CDDI phantom. Are there data?
Yeah, I mean, the 16 centimeter CT, if you use a phantom to do the CTDI with a 16 centimeter, and if you look at the change from PMMA to breast tissue, that's more like about a 22 to 23, because a 4.3 cm PMMA is equivalent to a 5 cm breast, and 50-50 composition at lower end. Of course, you have to look at what energy you're using. That's important too when you're looking at that. So, and the other thing is that this is for a cylindrical shape with your head phantom. And there's already studies from Sarno and Metivia that show that the cylindrical phantom, when you use that, you get a different dose estimate compared to a semi-ellipsoidal shape. So there's many factors there. What's the energy? What's the equivalent in terms of breast dimensions when you use a cylindrical phantom?
I see, but the 6% dose reduction that you are able to obtain by having basically...
Oh, the 6% dose reduction is, if the way we are doing is basically homogeneous breast. If you actually take the tissue distribution, it's 6% lower than a homogeneous breast. We are not going cylindrical versus that. The reduction when you go short scan is about 50%.
So a breast CT would be ideal to manufacture or to use bow tie filters that are adapted to the breast very well in order to make the breast become a cylinder. Is something like this used in breast CT?
Right now they don't. We've had a bow tie filter design, and one of the things is the variability between patients in terms of, and Dr. Boone has a bow tie filter design where he has similar to a 2D bow tie plus a third which is a rectangular, this one which you can vary. And of course that's Calendar, their group had a bow tie which could move back and forth to adjust for the breast dimensions, because you change effectively the fluence by
I rather consider a cylinder that is a negative breast, so to say, maybe different ones for different breast sizes, and you put them in the system and then put in the breast. So
yes, definitely. There's actually our bow tie filter design was based on that, finding that negative breast and then generalizing it across all breast sizes. That's how we designed a bow tie filter. But none of the systems today use bow tie filter.
Okay, great. Thank you.
Very, very quickly.
Very quick question. You said your final, very nice talk. Your final goal is to replace the screening with the breast CT. I wonder what is the radiologist's view on this, because that I assume that would increase their workload a lot.
Actually, it isn't. They actually find that the thing is, the trade-off is that if it reduces your recall, you do less diagnostic. So it's the time per interpreting a scan here may be a lot longer, but you do less diagnostic. And actually, the time per interpretation is not that long, because we don't look at each slice individually. It's basically, you do first for calcifications, we do a MIP through the whole volume. So, and then for masses, we do a scrolling average of 10-20 slices. It's just a movie that just plays through, and that's how probably the interpretation takes about 2 minutes.
Okay, thank you.
Thank you.
Okay, that's a great discussion. Let's thank the speaker again.
Thank you.